Hi, um, welcome again to this education channel. I'm Salah Abbas. I'm Associate Professor of Surgery at Deakin University in Victoria, Australia. Today I'm going to talk to you about dysphagia, and we will try to keep it as simple and as manageable as possible. I do want you to look at it in a simple why? Because the topic can be too complicated to comprehend if we dive too deep in the details. But from this lesson, hopefully, you will learn how to assess someone with dysphagia to start with, and then we leave the management of individual conditions to other lessons. It will be important for us before we assess dysphagia to understand at least the muscular component of the process of swallowing. Now, swallowing starts with the bolus and the that been after chewing, the tongue will get elevated or move posteriorly, and both of these movements, elevation and posterior movement, will thrust the bolus into what we call the hypopharynx. This will be immediately associated with elevation of the soft palate, and the function of the soft palate in this case, or this movement, is to protect the airways, prevent the food from refluxing back into the nasal passages. That will be followed by elevation of the hyoid and the larynx, and by this movement, it will open up the retropharyngeal space, which comes after the hypopharynx. With that, the epiglottis will tilt back. The main function of the epiglottis is to protect the larynx and the airways from food and fluid during the process of swallowing, stop it from going into the airway passages. Once this has happened, all this process is partially voluntary and partially involuntary, especially the function of the upper or the superior esophageal sphincter. Now, the superior esophageal sphincter is 5 centimeter in length, and it's mainly composed of the cricopharyngeus associated with other muscles. Um, and once the sphincter opens, the bolus will be in the esophagus, and that will initiate the reflex, which will lead to contraction of the esophageal muscles or the peristalsis, which will generate an intraluminal pressure of somewhere between 60 and 80 millimeter mercury, and in order to push the bolus downward. This will also be assisted with gravity. The reflex itself is mediated by the vagus nerve, so it's under no control, which make the esophagus kind of a complex organ. The cervical part is more or less partly under the movement is partly under control. Then it's involuntary in the chest and the part that is in the abdomen. Now we'll elaborate just a little bit about the peristalsis of the esophagus and the structure of the esophagus itself. The esophagus is a little different from the rest of the gastrointestinal organs in the way that it has only a mucosa and a muscular layer, and it does not have serosa. Only the intra-abdominal part is covered partially with serosa anteriorly. And the peristalsis in the esophagus, we don't need to be carried about that too much, but we just need to know the basics. And the basics is that we know the primary uh, uh, peristalsis, which will be initiated by the process of swallowing, and that's the main function of the esophagus. Secondary peristalsis do happen uh, in between the swallowing acts when we are not eating or drinking, and this occur as a result of distension of the esophagus with saliva or air, uh, and that will lead to, in that case, the esophagus need to clear itself. So it's just a matter of a housekeeping job to ensure that the esophagus is empty all the time. There are tertiary movements, and these movements are localized, they are non progressive, they do not lead to actual peristalsis, so they do not participate in the propelling action of the swallowing, and their function is basically unknown. We need to know the lower esophageal sphincter, which I have discussed in a previous lesson, that it generates a resting pressure of somewhere between 5 and 25 millimeter mercury, and that would keep the gastric contents out of refluxing back into the esophagus. And this sphincter is 2 centimeter in length, and it's also assisted by the fact that part of the esophagus is intra-abdominal and exposed to the abdominal pressure, and also the fact that we have got the crura of the diaphragm that helps the sphincter mechanism. Now, once we get a dysphagia, as always, if you think about any clinical topic, think about what the possible causes could be. And in the case of dysphagia, cancer of the esophagus will be the main concern because, and that's why dysphagia is usually a serious symptom. Benign strictures, and these strictures could arise from ongoing untreated reflux. They do happen in the lower part of the esophagus. Also, see benign strictures could be seen in connective tissue disorders such as scleroderma and other problems related to connective tissue inflammatory problems. Also, benign strictures would arise from someone swallowing a corrosive material by accident or by sabotage or an attempted suicide. Alkaline materials are more damaging to the esophagus than acidic material, because benign materials, alkaline materials, sorry, rather, is basically the bleach that's used in every single household, and it leads to coagulation necrosis of the rather liquefaction necrosis of the tissues. That's why it can erode into a deeper thickness of the wall of the esophagus than the acid. Acids usually lead to coagulation necrosis, and the damage is usually superficial. Anyway, this is a different topic, but we need to know the causes of strictures. Achalasia of the cardia is a disease of unknown etiology where there is increased pressure in the lower esophageal sphincter, and that problem is of totally unknown cause. It's a neurodegenerative issue, probably, and happens in young people between the age of 20 and 50. And I will try to go over the management of achalasia in a different lesson. Now, scleroderma and connective tissue disorder, as we mentioned, part of the benign strictures. An important problem is that sometimes we find absolutely no cause, and this could be a part of the esophageal dysmotility syndrome, and they tend to be difficult to treat, and there is no known cause for them apart from they are degenerative process in the neuromuscular apparatus of the esophagus. Diverticulum of the esophagus can happen anywhere in the esophagus. They are rare. It could happen in the cervical part, which is called the Zinker diverticulum. It could happen in the thoracic or the abdominal part of the esophagus, where it's called either epiphrenic or periphrenic diverticulum. And the management for these conditions is usually surgical, but we will need to find the cause first. Now, the esophagus is one of the least accessible organs to clinical examination. So we rely on two things to diagnose the problem of dysphagia, and these two things will be either would be both the history that we will get from the patient and also the investigations. Now, with any patient who come With dysphagia, you need to know the duration of the dysphagia. Did it start to gradually and deteriorate, or it was all the same right from the beginning? The duration of the symptoms would give you an idea. Usually, malignant strictures lead to dysphagia in a short period of time. Do they have pain with it? Is there any regurgitation of food? Is it solid and they have to drink some water to get the food to go down? Weight loss, anemia, and malnutrition are very common in these situations, regardless of the cause, and that should be assessed thoroughly with the known measures. We need to know always if the patient is a smoker or heavy alcohol consumption, particularly people who drink spirits. Now, both smoking and alcohol ingestion are high risk for cancer of the esophagus. So we need to know that in every single patient. I want to know their history of reflux and the process of gastroesophageal reflux that we have discussed in previous lessons. So you need to ask specific symptoms about reflux. Did the patient have previous endoscopies, and how recent is the most recent one? Do they have respiratory symptoms? Because you find often people who have strictures or cancers, they might get silent aspiration where they develop cough and wheezing and shortness of breath. Physical examination is mandatory, but as I said, there will be little to find from physical examination. Now, any patient who comes with the symptom of dysphagia after their clinical assessment and going over their medical history and medications, we will need to do two things. Number one, they will need endoscopy, and that's an upper GI endoscopy or a gastroscopy. It will enable us to have a direct look at the entire esophagus, the pharynx, the larynx, also the stomach and the duodenum. If there are any lesions, we do biopsy them. We have to notice the size of the esophagus. So in people who have got achalasia or chronic obstruction, for benign reason, the esophagus will be severely dilated with usually some residual food as stuff is still in the esophagus. Normally, the esophagus should be totally empty in a fasting patient who come to gastroscopy. If there is a stricture, we will be able to see that, and that's the upper or the top image shows you a benign reflux-related stricture. If there is any ulceration, that can happen as a result of Barrett's esophagus, which is another topic that we will need to cover. And then or severe form of ulceration as a result of uncontrolled reflux disease. It's mandatory to biopsy these, and when we biopsy the esophagus, we aim at 4 quarters to take minimal 4 biopsies per centimeter of the lesion. Any polypoid lesions should be noticed, and as we see in this picture, there is this polypoid mass, and this is during gastroscopy for a patient with cancer of the gastroesophageal junction. They often do look like that. We take biopsies to prove the pathology. Also, we need to see if there is candida infection in the esophagus, which will appear in the form of white plaques on the wall of the esophagus. You can detach them easily, and it looks like any candida or thrush, just like it looks like in the mouth as well, so it will be very easy to recognize. We take note of all these things and we take the biopsies, and usually while the patient is waiting to have their gastroscopy, we send them to radiology to have an upper GI study at least. And the upper GI study, we start with barium swallow. The benefit of the barium swallow, it will show us the details of the anatomy of the esophagus, if there is any diverticulum, if there is any stricture, hiatus hernia, and any holdup of the contrast during the process of swallowing, which is the delayed emptying of the esophagus that will happen, which is non-specific, but it will happen in any stricture or achalasia or neuromuscular disorders. Um, it gives us a good idea also about the motility of the esophagus, and it's a good study to have to assess as an initial measure to assess the motility of the esophagus. Now, whatever we find, or occasionally we find a duodenal diverticulum or benign lesions, and then we treat them, and it's over. But if there is any concern or doubt that the patient could have malignant lesion or prove to have malignant lesion anywhere in the esophagus, then we will need to do a PET scan and assess them for radical treatment. I hope this has been a good lesson for you to understand how we think about dysphagia and the initial basic simple workup. Then the individual conditions that causes the dysphagia will be treated accordingly, and we will cover that in different lessons. Thank you very much for watching that today, and I will look forward to seeing you in the future. Leave me your comments or suggestions under this video, and I'll try my best to respond when I have time. Thank you.